So this topic we're going to talk about, I get the opportunity to work with lots of data sets, as I'm sure you do as well. But the data set that I'm probably most familiar with, that I've used most over my career, is probably the inpatient data set, the admitted patient care data set, the SUS data set or HES equivalent. I've probably been working with that for 20 years in different ways. I don't like to think about how many working days I've probably spent querying that data set. But even though I'm sort of feel very familiar with that data set, I still, every now and again, I spot something in it that I've never seen before, that kind of surprises me. In fact, more likely somebody else draws that to my attention, because actually when you look at something repeatedly year after year, it's very hard to see it with a fresh pair of eyes. And Andrew was doing a piece of work a few years ago, and one of the outputs in that analysis showed this very large group of people who get admitted to hospital in an emergency, and yet in their discharge episode, the primary diagnosis is not a specific diagnosis. It's just a sign or symptom, something like a headache or an abdominal pain or dizziness or something like that, syncope, not something like COPD or heart failure or diabetes or fractured neck of femur. Yeah, that's a clue, Andy. Yeah. And I don't know, it feels like this group has been kind of hiding in plain sight for me anyway. It just feels like it's there. I've obviously known those diagnosis codes, those signs and symptoms codes exist. I've seen them in patient records, but I don't think I've ever looked at that group in and of itself and tried to understand what is going on there. So just a few things about that group. So first of all, these are people who've been admitted to hospital in an emergency. Now, being admitted to hospital means you're going to be using a bed, which is a very scarce resource in the modern NHS. So we don't take those decisions lightly. You have to be pretty sick to get admitted, or you have to be particularly worried about you. And usually, at least one clinician, usually several, have looked over you before that decision is made to admit you. Either a GP or someone working in ED, and or someone in ambulance services, for example. You've gone through various other filters before a decision is made that admission is required. And I know these days we've got various versions of that. We've got AMUs and SDECs, but nonetheless, we're talking about something over and above just an ED attendance or a GP consultation or an ambulance conveyance, for example. And then the other thing to note is that this thing of attributing a diagnosis is a really important part of the medical process. It guides treatment decisions, it gives information about prognosis, and it's really important to patients and staff. Before you get a diagnosis, you know you've got some symptoms and you're worried about what might be behind it. And diagnosis might not be good news, but at least it's something definitive that you can get your head around and start planning for. And absent of that, I think it leaves you a little bit in limbo. So getting a diagnosis really is important in most cases. And some of the work that Andrew had done a few years ago kind of hinted that this risk of being discharged without a diagnosis wasn't evenly distributed across the population, that there were some subgroups that was more likely to pay, demographic subgroups, that was more likely to be the case for than others. So for lots of reasons, we thought this was probably a group of patients we should pay more attention to and do a bit of concerted piece of analysis on. And we were incredibly fortunate because the Health Foundation agreed to support us to do some work in this area. And we did a project which had three components to it. First of all, we did a summary of the literature on this topic, which I'll take you through in a minute, the headlines from that. And then we did a descriptive analysis of the data set, just trying to describe who these patients were, and how many they were, what their characteristics were, what their service use was before and after the incident, to get a better, richer picture of what was going on with these patients. And then finally, we did some interviews with clinicians just to try and test out some of our theories, ask for their views on what was happening with these patients, why was this happening, what were the mechanisms at play, for example. So that's what we're going to try and take you through this morning, those 3 bits of the project, and then our sort of conclusions and views about those groups. So I'm going to start with a literature review. The literature review is quite difficult, actually, because searching for these papers on this topic is quite difficult because it's quite a nondescript, by definition, patients who are discharged without a diagnosis. If they were discharged with a diagnosis, we'd be searching for those diagnoses, but because they didn't have them, it's quite a negative search we're doing. And actually, the language that people use to describe these patients has shifted around quite a bit over the years. And so, yes, we needed Alison, who's our expert on literature and evidence and knowledge, to guide the literature search for us here and carry out the literature search. The headline is that there's not an awful lot published on this cohort of patients per se. We found 2 UK papers. One was an empirical study, one was a literature review, and 1 Danish study. The Danish study was a multi-site study. There was quite a lot on an aligned group of patients, which are those patients who attend and are discharged from ED without a specific diagnosis. There's quite a bit written about that group of patients, and we thought we'd look at those because we thought a lot of the findings and implications about the group that we were interested in, these people who are admitted to hospital and discharged without a diagnosis, we thought there'd be parallels in the literature about the key findings for those patients. And a very broad brush summary of what that literature tells us is that the literature is trying to wrestle with 2 very, very different questions. And I'm just going to share my screen here if I can now. Can I just check you can see my screen now, Rachel?
Yeah, perfect.
Great. So the first question these papers are wrestling is whether we really should be admitting these patients. Whether opportunities were missed earlier in the escalation process to divert these patients elsewhere so that admission wouldn't have been required. So a lot of the literature is focused on that question. And then the second question is a very different question, which is that is a worry that clinicians have that maybe they've missed something important with these patients and we've discharged them with something seriously wrong with them that we should have identified. And those studies are focused on, do these patients later turn up with a cancer diagnosis or another very serious diagnosis, or do they die shortly after being discharged, for example? So you get these sort of very, very different perspectives on this group, two very different concerns. One which is very focused on waste and efficiency, and the other which is focused on harm and quality and outcomes. And that's what the literature seems to be wrestling with. Which seems like they're wrestling at two very different ends of the spectrum here. One concerned with triviality and waste, and one concerned about serious harms that maybe these patients are experiencing. And the literature just hasn't really settled on a view on these things. It seems to be, the more and more has been added to the literature, but we haven't really settled on a view about these patients, I don't think. What we have settled on, though, more and more is a language for describing these patients. And the language that the literature is adopting are patients who are discharged with a non-specific diagnosis. That's the language that's being used to describe these patients. So I'm going to pass over now to Andrew, who's going to take us through the descriptive analysis, and then Andrew will hand back to me and I'll take you through what the clinician said about these patients and try and summarise our conclusions at the end. Over to you, Andrew, if that's all right. I'll stop sharing my screen.
Yeah, so I'll be rehashing a bit of what Stephen said already. But starting from the very basics, when a patient is discharged from hospital after an emergency admission, we have an electronic record of their stay. And one of the key items in this record is the patient's primary diagnosis. In admitted patient data sets, primary and any secondary diagnoses are usually shown as ICD-10 codes. And this classification is divided into 22 chapters, and the majority of chapters relate to diseases or other morbid conditions. But among the exceptions is chapter 18, which is reserved for symptoms, signs, and abnormal findings, not elsewhere classified. So as Stephen said, this chapter can include codes for things like headache, abdominal pain, tendency to fall, rather than for specific diseases or injuries. And when a signs and symptoms code is recorded as a patient's primary reason for admission, it implies the consultant team did not reach a view on the patient's medical diagnosis. What we do know is that diagnosis is obviously central to the wider medical process, and if opportunities to diagnose and be missed, then we'll get poorer outcomes for patients and for the health system. Now, again, as Stephen said, this project was motivated by the findings of work we did a few years ago, which reminded us that the signs and symptoms diagnosis group is large, another hint, and is one we often overlook. Mainly, I think, because we don't have a clear idea of who these patients are. We might be able to visualize patients admitted with a stroke or with a broken leg and have some idea about their journey through the hospital and their outlook. But what kinds of patients do we imagine when we think of symptoms and signs diagnoses? So, yes, I'll be sharing my attempt to organise and contextualise the raw statistics about these patients, and then I'll hand back to Stephen to tell you about the work he did, which builds on these statistics. One more thing, I'm going to abbreviate symptoms and signs to signs diagnoses to save time. And as Stephen said, I might also refer to non-specific diagnosis, by which I mean the same group. Right, so in 23-24, there were 6.3 million emergency admissions across England. And can I reveal the number now? The percentage of patients?
Should we invite people to, if they haven't already, to on Slido to say what they think it is. So if you are in Slido, the question is that you're about to reveal is what percentage of patients admitted in an emergency leave hospital without receiving a specific diagnosis. And I'm not quite sure who can. I think if you're logged into Slido, you can see the results, is what I think. So the people here who are in there participating can see the results. But do you want me to share my screen for those who can't, and then you can do the big reveal, Andrew. I may be building this up. I realise that.
Yeah.
Don't worry, it's fine. I take every opportunity. So this is what people think. So they have a choice.
Okay.
So some people, not many people. So these aren't. You can see they're in order of number. People have selected those. So what do you think about that?
That's surprising to me. I wonder if we hadn't given the bands and we just asked that question, whether we get a different answer, because everyone we've asked previously has suggested, without the hints, a lot lower percentage. Or maybe this group is just very well informed.
Well, I was just saying we gave them loads of hints. We gave them loads of hints. They are an incredibly intelligent group. They have a lot of insight into this time. They've probably done lots of analysis on this as well. We also gave them lots of hints. So, but I agree. I think so. I've done lots of work on this in the past as well, a long time ago with my big ICD-10 book, which I think I've still got a copy of, stolen most likely. But yes, so this is. I'm glad you find it interesting and surprising. I'm going to stop sharing my screen, and I'll let you move on. But interesting results and a well-educated crowd.
It seems to demonstrate the wisdom of crowds as well. Although whoever's just voted has tipped that. Although maybe they're referring to the female group. But yeah, let me share. Okay, so 17% of cases, that's 1 in every 6 patients left hospital with a non-specific diagnosis. So we summarized the characteristics of the signs group and compared these characteristics to the characteristics of the 83% of patients who received any other primary diagnosis, who I'll call the reference group. The table here should hopefully be in a fairly recognizable table 1 format. Unfortunately, I'm illustrating a lot of the figures in tables, which I apologize for, but that's how we did it in the report, and I haven't had a chance to present them in graphics. Yeah, in the right, where are we? In the right-hand column, we've got colors that indicate how category percentages are distributed within the signs group and how they are distributed in the reference group, or how to compare how they're distributed. Right. So purple shade means that the subcategory is more prominent in the signs distribution, and the green shade means the subcategory is more prominent in the reference group distribution. So to the numbers, 56% of the signs cohort were female. The age profile of the signs group was younger than that of the reference group. They had fewer comorbidities and fewer prior or subsequent admissions. They're also more likely to be admitted in response to a GP request and admitted during the day and on weekends, and to be treated under general or emergency medicine specialties. And a much higher proportion of the signs group were discharged without receiving a medical procedure and discharged on the same day as their admission. Incidentally, they were only marginally more likely to self-discharge. Looking at the non-specific diagnoses given to the signs group, we see that chest pain, including precordial pain, and abdominal pain together account for close to 40% of all signs diagnoses, and tendency to fall, headache, and syncope are also they also feature frequently. Just returning to the first table I showed, we see that the age profile of the signs group appeared to be appreciably younger than that of the reference group. And looking more closely, if we make a plot with age on the horizontal and number of admissions on the vertical, we see that for females in the signs group, the number of spells by age remained relatively high, right from 18 through to 85, which is certainly a very different distribution to the one we see for all other diagnoses combined. And there was also a difference with males, though it was less pronounced. But these differences across age group have further implications. We've seen earlier that overall, 1 in 6 spells following an emergency admission resulted in a non-specific diagnosis, but this proportion varies by age and sex, such that around 1 in 4 females in the age ranges of 14 to 23 and 40 to 50 who were admitted to hospital in an emergency were discharged with a non-specific diagnosis. For males, it's around 1 in 5, and that's between the ages of 20 and 45. And as you might expect, the diagnoses themselves vary considerably by age and sex. So looking, for example, at this graphic with panels to show each of the most prominent non-specific diagnoses for females, again with age on the horizontal and number of spells on the vertical, we see non-specific diagnoses that are largely given to young children here, for example, fever, or to older people, like tendency to fall. But outside these extremes, we see abdominal pain and chest pain making up a large number of sign spells for females aged 18 to 64. Abdominal pain is much higher among younger females, while chest pain diagnoses peak in middle age. So as we might expect for a not otherwise classified category, there appears to be like distinct subgroups within the cohort. And so to make further analysis clearer, we decided to become more specific about our interests. So based on the varying diagnosis by age and the age profiles, we decided to perform a closer analysis of patients aged between 11 and 64, looking at females and males separately. And the rest of what I will show you will relate to these two groups. I'll also add that the reference groups have been narrowed to match the sex and the age ranges. So with a few exceptions, we saw the same kinds of characteristics emerge for the 11 to 64 groups, though the differences were often more pronounced. So the science group had fewer comorbidities, they had fewer prior or subsequent admissions, they were more likely to be discharged without a procedure and to be discharged without an overnight stay. But we also, for this group, looked at the secondary diagnoses and the subsequent admissions. So for both females and males, though I show just females here, around half of the sign spells included one or more secondary diagnosis codes within the factors influencing health status chapter. These codes represent social circumstances or significant medical histories or conditions that influence how the patient was cared for. But we also see that for females and males, in fact, 40% of sign spells included one or more additional non-specific diagnosis code, and 30% included one or more code relating to mental or behavioural disorders. I'll add that a patient may have multiple secondary diagnoses, so these groups aren't mutually exclusive. In terms of subsequent admissions, for both females and males, when a patient was readmitted within 90 days, which happened in around 30% of cases, more than 1 in 3 of these readmissions were followed by another spell with the signs primary diagnosis for that patient. And this was by some margin the most common outcome for patients who were readmitted. Anyway, that was a whirlwind summary of the characteristics of these patients, and I'll move on to briefly cover inequalities in diagnosis rates. So are some groups more likely to receive a non-specific diagnosis? So here, for the sake of brevity, I'll omit the work we've done on inequalities across deprivation deciles, which suggested that those living in the most deprived areas were about twice as likely to be discharged without a diagnosis as those living in the least deprived areas. And I'll just cover inequalities by ethnic group and by sex, which is where I will begin. So for females aged 11 to 64, the age standardized rate of sign spells was about 18 per 1,000 population, whilst for males in the same age, the rate in the same age range, the rate was about 12 per 1,000. So females therefore had about 1.5 times the rate of males. And this can be compared to 1.2 times in the reference group. And the 50% difference between females and males seemed to be fairly consistent regardless of the socioeconomic or ethnic group we were looking at. So females from a given ethnic group tended to have a 50% higher age standardized rate of sign spells than males in that same group. So the pattern across ethnic groups was very similar from females and males. So here I'm showing standardized rates for females. So the ONS group, Black, British, other, had a relatively high rate of sign spells compared to the white British group. It was twice and 3 times that of the white group for females and males respectively. Asian, British, Pakistani, Bangladeshi and other groups had higher rates than the British group. Conversely, the Asian, British, Chinese, the Irish, and the mixed or multiple ethnic groups categories tended to have significantly lower rates of sign spells than people in the white British group. And then we use measures based on the index of disparity to compare inequalities in these rates across patient groups and over time. That is, we also looked at the situation pre-COVID. And this suggested that in 2023, for females with signs diagnoses, the relative inequality across ethnic groups was slightly lower than it was in the reference group. And inequalities appear to have reduced since 2019. For males, the opposite was actually true. Relative inequality across ethnic groups was slightly higher than in the reference group and appears to have risen since 2019. So inequalities in diagnosis rates do exist, and they do appear to be contributing to inequalities in general emergency admission rates, but they're perhaps not driving inequalities as much as we feared, given the hints that we saw in the previous work. Anyway, that's a quick and relatively intense summary of the statistics. Yeah, I'll hand back to Stephen.
Thanks, Andrew. We've covered the literature review very briefly, and I'm just taking us through the descriptive analysis. I was going to take you through the qualitative work we did with clinicians next. So let me just share my screen again. So, well, in this area, two colleagues, Abby and Bethany, did some semi-structured interviews with a set of clinicians that work in this area. And essentially we shared with them the descriptive analysis that Andrew's just been through, and we asked them for their reflections on what we'd found. You know, did it match with their experiences? What do they think about the mechanisms at play? What were their views on the inequalities issues that we identified? So we had a set of prompts to ask them, but there was some freedom within the interviews for them to give us other information to explore issues. So I'm just going to take you through a very brief summary of what they told us. If you're interested in a finer level of detail on this, there is a separate report linked to on our website where you can see the a very detailed description of the outcomes of this qualitative work. So if you're interested in the next level of detail, it's available for you if you want it. So the first thing to say is that in many ways, what we were sharing with clinicians, they were kind of saying, well, that's matching our experience. So they didn't think there was anything sort of fundamentally wrong with our analysis. They don't think somehow we'd misunderstood the data and misrepresented what was actually happening. They were comfortable with the volume of patients who were identifying in these categories and roughly their distribution. But they also told us a bit about what they thought some of the mechanisms were at play here. They talked quite a lot about patients being admitted where the main objective was to give them a place of safety, not to diagnose or treat a medical condition. And they felt that was a growing issue that was occurring in hospitals. So even at the point when the patient was admitted, there was a view that there was nothing medically wrong with the patient that needed treatment, but they needed the person needed somewhere to be safe for a while, whilst other things kicked in. They also talked a bit about patients with complex presentations where it probably wasn't feasible to diagnose the patient within the admitted patient stay. And indeed, after the patient was stabilised, it may have been appropriate to discharge the patient, but subsequent work after the discharge should have led to a diagnosis, further outpatient appointments, for example, further tests. And it's just not feasible for some of these patients to reach a view within the inpatient stay. So those are the sorts of issues they talked about in terms of mechanisms. We asked them about the overrepresentation of women, and they kind of felt that they weren't surprised about the overrepresentation of women in the younger age group, the sort of 14 to 25 8-year age group. That matched their experiences, and they felt they had some theories about why that was the case. They were less cited about the overrepresentation of women in the second age group, the 40 to 50-year age group, and they were kind of theorizing that maybe that was related to menopause. In terms of the reasons why we're seeing overrepresentation of women in these groups, they talked about medical misogyny, they talked about normalizing female pain, they talked about lack or absence of pathways for certain sex-specific gynecological conditions. When we talked about the overrepresentation of certain ethnic groups, particularly Bangladeshi and Pakistani groups, they were less clear about what the reasons for those might be. but they speculated that maybe there were some issues about language, about suboptimal communication between the patient and the clinician that led to a no specific diagnosis outcome. Maybe some cultural disconnects, which mean that clinicians were misinterpreting what patients were telling them. Institutional biases came up as a possible explanation. And they also talked about the possibility that maybe some patients are discharged with lower thresholds because the prevailing view is that we can rely on our health system more on informal care back home for those patients than we could, for example, for white ethnic groups. And they also talked about the negative consequences for this group. So they kind of acknowledged that there could well be some negative consequences of being discharged without a diagnosis, and in particular about the stress that leaves patients and an uncertainty it leaves patients and carers with. So they've gone into hospital, they've been admitted, but nobody's told them what is really going on with them adequately so that they can be reassured and know what's going to happen next. There was also a concern, or they kind of talked about a concern they have about over-medicalising some patients. But they said, in theory, we could have done many, many more tests on these patients, and eventually we could have tracked down maybe what was wrong with them. But they weren't sure that was in the best interest of the patient always. Just constantly testing and being more and more certain about things maybe wouldn't have added value here. And they said sometimes discharging a person without a diagnosis is the optimal outcome, but it required a very confident clinician to do that in many cases. And I think here we're seeing that tension that came out in the literature again about, should we be doing more for these patients to try and pin down what their diagnosis, or should we be, changing our upstream pathways to divert them earlier on so they don't get admitted? I think those tensions are emerging again in our conversations with clinicians. And having put together what the clinicians were telling us, what we saw in the literature and what we saw in the descriptive analysis, we came to the view that really what was happening here, what we needed in order to make progress in this territory, was a bit more of a sense of a classification of these patients that helped us understand what was happening in their particular cases and therefore guide our thinking about service improvement opportunities. And thinking of them as a homogeneous group, which probably wasn't very helpful. We needed to be more specific about these patients and understand some of them. And the classification kind of emerged quite naturally from the conversations with clinicians and from the literature and the descriptive analysis. And essentially, we've arrived at these 4 classes of patients who are discharged without a specific diagnosis. And we're interested in people's views on this classification. The clinicians thought it was worthwhile and valuable and felt that it would help, but we're interested in more perspectives. It's just a conceptual framework at the moment, so we haven't attempted to count people within these classes. All we've done is describe them in a bit of detail. So the 4 classes that we've come up with, first of all, we've got a group of people the reason why they're admitted and discharged without a diagnosis is primarily because they were experiencing psychosocial distress of some sort. They were admitted primarily for reasons of safety rather than for medical diagnosis or intervention. So there is that this is one group of patients that we're picking up in our set. A second group is these patients who are admitted with relatively minor conditions. So their symptoms would have been really important to the patient, and other people upstream would have deemed those symptoms sufficiently serious to warrant the admission. But maybe those symptoms resolved naturally during the inpatient stay, or were deemed medically minor by tests that were carried out on the patient or observations carried out on patients whilst they were in hospital. And they were discharged and no further attention was regarded necessary here. So that's our second group. Our third group are these patients with very complex presentations, where the patient was admitted necessarily and stabilised within the inpatient stay, but diagnosis required tests, many potentially subsequent tests, before a diagnosis could be assigned to the patient. And the fourth group are this other group of patients that we're worried about, which is about where a diagnosis was missed within the inpatient stay. So they were admitted for a condition harm subsequently. And what we've done in the long read, which is available on our website, is we've kind of teased out these 4 groups in a bit more detail. We've tried to describe their characteristics. And we've tried to say, well, if you were thinking about improving the care for these groups of patients, how might you go about it? Just some initial hints and ideas about how we might improve the outcomes for these 4 groups of patients. And we're just hoping that just simply by breaking down this big group into a smaller set of more specific groups, then it will guide more effective service improvement efforts in the future. One of the things that we've done in the long read, which is available again on our website, we'll put a link in the chat maybe at the end. As we were working through the project, lots of subsequent ideas for potential research or analysis came up, and so we've listed 5 of those. And we'd be quite interested in your views at the end about which of these you think would be most worthy of attention and effort and resource. We don't have any resource, but we'd be interested in your views about which of these would be most interesting. So I think we've got a Slido question, is that right, Rachel, about these? I'll take you through the 5 things that we thought might be worth doing, and then I'd be interested in your views on which were most potentially fruitful lines of inquiry. So the first is to do some more work on the classification, to define the classification a bit more, such that we can assign people to these 4 groups with our routine data sets. It won't be perfect, but it will be some sense of which class patients might belong to, depending on their characteristics within the inpatient data set, or by linking the inpatient data set to other data sets that we have information on about these patients. And that would allow us to scale these groups and to describe them in more detail individually. We have no sense at the moment of the relative scale of these 4 groups. And then potentially after that, we could do some clinical validation of the classification. We could work out, compare the assignments of an algorithmic approach within our data sets to assign people to these classes, and compare them to what clinicians working with those patients actually think was going on with these patients, to see the extent to which our classification was clinically valid. So they're the first 2 potential further lines of inquiry we could follow up with these patients. The next 3 are a bit more specific and focus on inequalities aspects of this phenomena. So the first question we thought would be really interesting to answer is to look at the risk that a patient will be discharged with a non-specific diagnosis, having control for other case mix factors. But we were interested to see how that varies by the sex or gender of the clinician. So we have the sex of the patient from the inpatient record, and we can pick up the sex of the clinician by linking their clinician code to the GMC register. That does hold information about the sex of the doctor. So our theories here would be, are women who are seen by female consultants more likely to be discharged with or less likely to be discharged without specific diagnosis than if a male consultant saw the patient? And if we do see differences, then that might give us insight into, again, how we might improve the quality of care for these patients. Number 4 is about this issue about the fact that we're seeing overrepresentation of certain ethnic groups, particularly Bangladeshi and Pakistani groups within the non-specific diagnosis set. And one of the theories that the clinicians talked to us about was about language barriers, about access to translation services. And we don't have data in the inpatient data set on the English language skills of the patient, but we do have other data sets that tell us the distribution of English language skills by ethnic group within the wider population. And we thought we could do some work to explore whether the distribution of patients with non-specific diagnoses in the inpatient data sets followed those other distributions of English language skills within those ethnic groups. And again, if we were to identify that as some association between English language skills and non-specific diagnosis, again, it might lead us to some suggestions about how we can improve the care for those patients. Access to translation, etc., which I know is a pertinent issue within hospital services at the moment. And then the 5th project that we're wondering about is about exploring the rates of and the timeliness of diagnoses for common reproductive female health conditions. So there was a House of Commons Select Committee that met a year or so ago, and they recommended that the NHS should track delays in diagnosis for certain benign gynecological conditions, endometriosis, fibroids, for example. And we thought it'd be worth doing a piece of work to say what's possible from routine data sets to track delays in diagnosis for those conditions. What are the waiting times? What are the use of urgent care services for women who are waiting for those diagnoses? Do they use more urgent care services whilst waiting? And maybe some qualitative work to explore the consequences of delayed diagnosis for those sorts of conditions. So those are our 5 potential projects. We've sketched them out in a bit more detail on the web page, but just even from that high level overview, we'd be interested in your thoughts about which of those potential lines of inquiry would be more valuable for the future. Get interested in your views about which ones to pursue. I'm going to finish there, Rachel, and hand back over to you if that's all right.
Yeah, absolutely.
Happy to answer questions, obviously, if people have any.
Yeah, sure. So I did invite people as requested to share their thoughts on which of those they would find most useful or they like the best. So I'll just share my screen on what people just said. So of the ones you just talked about, it was the one about English language skills and interpretation services, which and diagnosis in emergency care settings, which people, almost half, have voted for that. And you can see which ones people are finding most interesting or valuable for us to pursue with all the money that we've got available to us. I'll do a whip round, but that's interesting. Do you want to talk to that? Is that helpful to you, Stephen?
Yeah, no, it is. I mean, I think I'd probably be broadly aligned. The 3 research questions at the end, I think, are probably more interesting than doing further work to enumerate and define the classification. I think the classification can serve a purpose purely conceptually. We could do more work on it, definitely, but I think we'd probably get more bang for our buck, more benefit if we were to follow some of those specific research questions. All 3, I think, are interesting to me, but it's interesting that the English language skills one is coming out very high from our participants. That's really useful information from us. Thank you.
Okay. I've had 1 or 2 questions. Of course, I didn't remind people that they could use the Slido to ask questions during the session. But we have got 1 or 2 nonetheless, and there was 1 in the chat as well, which we can go to first. So if I just go to the questions which were raised on Slido, but before we do that, I'm just going to pick that one which was in the chat. I think the sun is affecting my ability to multitask. So Nathan says, would be interesting to know what proportion of these patients were waiting for tests or interventions procedures on a waiting list. So that's why, were they, did you have a look at that? Is that something that you think would be interesting? Of course it's that relationship between access to elective care at the right time and, having an emergency episode.
Yeah, it's a really good question, Nathan. That wasn't something we did in the analysis we were using, but now we have the waiting list in a data set. I think that question is answerable, isn't it? We know now at record level which patients are waiting for these on RTT pathways. It would be really interesting to know whether we're seeing lots of these patients being admitted and discharged whilst waiting for formal diagnoses or to be seen by a consultant. There is a view, isn't there, that we're seeing more and more failure demand within our health system. Where work is being done with patients because we didn't do something else earlier or quicker or better, and we're mopping up the effects of those more and more. Incidentally, a colleague, Alison Turner, has been doing a piece of work which is due to be published soon on failure demand in the NHS. So that's a concept. So I won't go into the questions that Nathan's answering, but it starts to explore this topic of should we focus more on failure demand in the future as a means to improve health service provision, improving productivity. But yeah, I think Nathan, your questions are a good one, and I think it's answerable, definitely.
Yeah, I think that might be one that we bring back to Huddle as well. Is that failure demand work? I think nobody particularly likes the phrase because they kind of understand what it's getting at. It means something isn't happening here, so it's having the knock-on effect somewhere else in the system, and it's not good for individuals. It's not good for sort of care planning and so on. So good, excellent question.
Shall I pick up Jacqueline's subsequent question?
Yeah,
I think it follows on.
absolutely.
So Jacqueline asked whether people are added to the waiting list shortly after a discharge without specific diagnosis. And what Andrew did in his analysis is he looked for people who had a first outpatient appointment within a certain period. I can't remember what the period we included now, but a first outpatient appointment in sort of a line specialty within a certain period. I can't remember exactly what the results are, but they're in a long read. But it does suggest that again, this complex presentation group, it is there. It is a feature within this data set. There are people who clearly the patient was discharged without a diagnosis, but knowing we had a plan to reach a diagnosis afterwards.
Yeah.
And I think that's what that shows up, and that's why I think it's important that we have this class of patients on this complex presentation pathways.
Yeah, absolutely. So just the third one in the chat, which is from Brenda, who says perhaps to track outcomes of all discharge without diagnosis. So these presentations demonstrate the value of a follow-up qualitative research. So that I'm sure we'd all echo that in terms of finding out the actual sort of the case studies, the stories behind some of the data that we've been showing today.
Yeah, some of the literature does look at some of those things. I think I mentioned that and some of the work that Andrew did. Andrew looked at subsequent admissions and outpatient appointments. I think, and there are papers that look at subsequent mortality, but a bit patchy at the moment, that research. I think something more more complete would be worthwhile, and longer term follow-ups as well might be useful.
Okay, so if I'm just looking at the questions on or the comments on Slido now. So that's the screen that I'm showing. So the first one here was like you've probably said some of this, but was there anything in particular that most surprised you when you started to investigate a bit further about the results that came through?
Yeah, I think the two things for me. One is just the scale of the group. Again, I just wasn't cited on that. It seems like when we asked the question at the beginning, other people may have a better view on that. But for me, it was initially very surprising to think that 1 in 6 people who get access to this very, very scarce resource of a hospital bed, we don't actually finish working out what's wrong with them. And I don't know. I'm not sure. So some of that might be perfectly legitimate. We don't know, but I suspect there is a little bit of failure in there that we need to which is affecting the health service, but also patients and carers. And I think there's probably more we can do to improve on that. And the second thing is the results relating to women. Again, kind of expected there to be some effects there, but the relative effects were quite large here. Women are much more likely to be discharged without a diagnosis than men are, and it is particularly marked into those two specific age groups: the very younger women, aged sort of 14 to 25, and a second cohort, aged sort of 40 to 55, I think we said. And yeah, clinicians, as I said, they were also kind of surprised by that second cohort. They hadn't recognised seeing that. They weren't really cited on that issue, I suppose.
I think that's quite telling, though, isn't it? If they're surprised, because usually it's like, yeah, I'm seeing that, I can kind of explain that. But if they're surprised, then you think, well, that is something to pursue. So the other question here, so looking at those 4 different patient classes or classifications, so I think you've probably covered this as well. It's kind of what does that reveal that is hidden by just looking at them as one big group?
It's not so much that it's hidden. It's just that I think that the improvement strategies for those 4 groups look very different. What as a health service we should do to respond to this issue feels very differently when we're looking at the psychosocial distress group than if we're looking at the complex presentation group. And trying to solve that problem while regarding the group as a homogeneous single entity.
It's not one answer.
And we end up with all these tensions about, well, should we just not have admitted these patients? Or on the other hand, should we have we missed something really important? And the reason why we're getting those tensions is because we haven't seen the subclasses, at least we haven't been explicit about subclasses of patients in this cohort. So that's how I think it helps. It helps us work out what to do next to improve things.
Yeah, and it's looking through those different lenses. It looks completely different, doesn't it? And things can be they can sort of shine out as to something that you can do differently, or because you're understanding that cohort better. So I'm just going to this bottom one here because that was on first. So related to that really. So how should services think differently about patients discharged without a diagnosis, bearing in mind that some of it is entirely appropriate, whereas others it is that missed opportunity.
Yeah. So
okay.
Well, to give some examples, if we're thinking about the psychosocial distress group, the question there is about whether or not we can find alternative, rapidly accessible services that are more appropriate than an inpatient stay for those patients when they present at ED or to their doctors. And it's an ongoing issue, isn't it, about making rapid access urgent care services for people with mental health problems. But the solution kind of looks in that territory, or upstream interventions to reduce stress or pressure on those groups. Interestingly, the peak is around the time, for the first peak, the peak is around the time when kids are doing their GCSEs. It's I wonder whether that's a social issue, that social phenomenon that's playing out here.
Yeah.
Then if we're thinking about the complex presentation group, then the question is how can we more rapidly access diagnostics after a discharge? And if we're thinking about the misdiagnosis group, one of the things that came across a little bit in the literature is this maybe this troubling idea of frequent flyers that we use a lot for it in ED. People are a bit worried that maybe that's introducing bias that the clinicians are picking up on. That might be just a shorthand for time wasters or people we just see on. We've seen them before. There's nothing wrong with them. Why are they here again? Just let's get rid of them. Whereas there might actually be a reason why they keep coming back into A&E that we're not picking up and resolving, that we should intervene with. So again, I think it's just the fact that there might be very different strategies for this group of patients that we think we could get.
That's really interesting. It's also very interesting that someone's pointed out in the Slido that there's been a lot of questions where people have been using the Q&A on Slido. Well, I didn't know how to use that. I know I had it open. I didn't know that. So, but there have been quite. So I think I'm sharing probably my version of that screen, and I will have to become educated before next time. Can you see some questions that they are right? So if you can do two, I know we're nearly approaching 12 o'clock, and this is a big reveal to everybody out there that I don't know how to use Slido properly, but there's some homework for me. If we could just pick a couple of those questions, and if it's okay, both of you, if I could share them with you afterwards, because I think there's some really good questions which will help you with those next pieces of work as well.
Yeah, I'm struggling to digest all the questions quickly enough to give you an answer now in the minute we've got left. So would you mind if I took them away and
yeah, absolutely. No, that's absolutely fine, of course. I will stop sharing, and I'm going to share something else while I'm doing this, because I'm just going to let people know what's happening next in huddles and so on. But yeah, thank you, Stephen, and for those who are disappearing, thank you for joining us today. Thank you, Stephen. Thank you, Andrew, for that really interesting session. My question was obviously, has anyone else got an ICD-10 book on their desk anymore? Is it just me and other old people? But I just want to say very quickly what's coming up in the next week huddle, because we've got so much. It's quite packed. I don't have any gaps. So the next one, really looking forward to this one. So this is about understanding the latest deprivation data. So we have a friend from the Health Foundation, Freya Tracy, coming to talk to us about that. They did a publication on that. Then we have the NLP model, which is developed for a council commissioned pupil voice, and that's in Swindon Borough Council. So that's going to be an interesting and a different topic for us to cover. We then go to a policy evaluation methods and examples with Alex Bottle, who is a professor at the Imperial College London. Then we are looking at domestic abuse in Isle of Wight, so another new topic for Huddles. And then the last one I've got on this list anyway is an introduction to R, or something else we decide to talk to you about, but I think it's going to be an introduction to R, and that's with Claire Welsh, who is a lead data scientist at the strategy unit. So that's it. That's all I'm going to talk about today. Just a mere 1 minute over 12, which I think is just fine. So now it's time for everybody to go run around in the garden and enjoy the sun. Thank you for coming, and thank you to Andrew, and thank you to Stephen for sharing that with us. Thanks, everyone.